in the thinking about the real world. But before I did that, I wanted to tell you a little bit about myself that you haven't heard from our chair here this evening. I live a rather strange life because I actually live in Norwich in England, the bottom arrow on the map here, and live and see patients there, but run our respiratory research unit in Aberdeen in the north of Scotland. Now, people often ask how you actually get between these two places. And it's interesting, there's actually 4 flights a day between Norwich and Aberdeen. Actually because of oil and gas, not because of myself. But actually these two cities are both very old cities. In fact, some of the wealthiest cities in the United Kingdom. Aberdeen, you can see from the slide here, has a very old university, over 500 years old. And then Norwich on the right, an old Norman city, over 900 years old. So actually very old and very wealthy. And I'll come back to that theme a little bit during the talk. But one question for you all, and this is probably one that I'm sure you're all going to know the answer to, and maybe you'll discuss it at your meetings, but one question is, why was Aberdeen wealthy long before it actually discovered oil? So I've given you 4 choices here. The first one is selling haggis, and you can see haggis at the top on the right of your slide here. And haggis, as you can see, is a one-legged animal that runs around mountains. Okay, it's not great. It's actually the sheep's stomach with all the bits of the sheep that you wouldn't normally eat. Or do you think it's from fishing? Or making kilts, you know, those skirts that Scottish men wear? Or finally, from whiskey? Now, I suspect, from having spoken at many meetings, that many of you are saying whiskey. And whilst I like the way you're thinking, you're actually all wrong. The whiskey comes from the rural areas, actually outside Aberdeen, and it's actually fishing that made Aberdeen so wealthy. In fact, it made them so wealthy that they call it the Silver Darling. Anyway, on to our subject of today. I want to talk about asthma and some of our thinking here. And asthma has been around a very long time. I mean, the word asthma comes from the Greek, meaning panting or shortness of breath. And in fact, Hippocrates, shown here on the slide, was actually the first to write about asthma. And his recommended treatment was to rest and take it easy. I hope that's not what any of you are recommending to your patients. And we've had guidelines. And it's been very interesting. I had an argument with some of my Australian colleagues recently who were trying to claim they had the earliest asthma guidelines in 1987. They said the British ones came out in 1990. Well, I went and did a thorough literature search, and you can see actually the fruits of this here. And here we have the oldest asthma guidelines, the Treatise of Asthma from 1698, and of course they're British, actually published here in London. You may say not much use, and actually maybe clinically they weren't much use, but there is an interesting theme that comes out in them. You can see it on your screen. It actually describes 2 aspects of asthma. The first is a history of the fit, i.e. exacerbations of asthma, and secondly, the symptoms preceding them, if you like, the symptomatic control. And one of the learnings we've been having over the last few years is actually to recognise these 2 different aspects of asthma. And while some of our treatments are great for reducing exacerbations, they may be less good for reducing symptoms and vice versa. So that heterogeneity of the asthma was actually recognised over 300 years ago. Now, the theme that I'd like to explore with you tonight is one of the term I've called effectiveness. And what I mean by this is actually how well our treatments work in our real world, our real life patients. Now, you've all seen data presented to you, and yet when you actually have a patient in front of you in your clinical practice, they actually don't respond in the way that you see in the clinical studies. And what I think is going on here is that actually when drugs are studied in an early stage for regulatory purposes, they're really studied in a very, very tightly controlled population of people. Rightly so. You want to look at safety, you want to look at predictable responses. And so, but actually, that's not a real-world population. So when we start to look at that real-world population, with a variety of factors, and I'll explore some of these later, we actually end up with quite a